Right, Roth.
Te aloha lava, kia ora. As you know, my name is Elijah, and I'm here with my colleague, Chris Higgs, who is also part of this research. And we are here today to present some of the findings from the research that we did there in Palmerston North. So, without further ado, we will start. I'll hand it over to Chris.
Yeah, kia ora koutou colleagues. I'm Chris. We'll introduce ourselves in a second. So the rough plan for the workshop is as follows. We'll just touch on who we are, just talk about the why. What are we doing this for? Set the scene. Then we'll present some of our findings. And those white comments there are just an opportunity, recognizing this is recorded. So we're interested to hear from you. What do you think about how we've interpreted this information? So we're going to share this recording with you, share the link, encourage you to watch it. Should be no more than half an hour, hopefully less. And then we'd really appreciate any response from you as to how you feel we've captured your voices and your stories and your suggestions. Okay. And just to be clear, this is not a critique of Health Hub. This is an exploration of teams working in primary care. Yes, we recognize this is work specifically looking at one practice, but we're really interested in teams and how they work together. So I'm a physio by background, working here in Dunedin, and my research interests sit in allied health, primary care, and supporting people with long-term health conditions. You would have met Donna, who also works here at the school in Dunedin, and her research interests are explained there. She's a non-healthcare professional, but always has got a valuable insights, thoughts, and suggestions. I don't know, Elijah, if you want to speak to you.
Oh, yeah, sorry. Yeah, my name is Elijah Areli, and I'm also a physiotherapist, and what's listed there are my research interests as well. So interested in chronic pain, primary health, and also Pacific health as well.
Yeah, and so just acknowledging we're coming from an allied health physio background. We're not GPs, we're not nurses. This is our interpretation and understanding of the voices and stories that we heard. So primary care, what do we know? This is perhaps the idea that the person's in the middle here, and they can seek care. The general practice might be their primary place that they'll seek care from, but there are other health and well-being services within the community too. And the hospitals there is a place that you might need to go to if necessary, depending on how acutely unwell you are. But really, it's about trying to keep people well in the community for as much of their lives as possible. And the wee comment here from General Practice New Zealand: modern general practice is no longer served by traditional 15-minute consultations and a practice team of GPs and nurses. Models of care continue to evolve nationally and internationally, and there is no one-size-fits-all. Rather, broad principles of a flexible, team-based approach in an integrated primary and community environment, focused around the needs of whānau. So sort of how and what primary care looks like, and what might look like in the future, I think is fluid and evolving. So broadly, we asked you about how you share knowledge, skills, and decision-making within a team. So we must and should share with you our results in this space. And it was broadly, you share knowledge with corridor conversations, or in your aspect, the physical design of the space that you work in allowed conversations to occur quite naturally, and that could help share knowledge. Equally with planned team meetings. I don't know, Elijah, if you want to speak to any of the other pieces.
And there was also talk of physical location, so just being placed in that hub, just being around there, whether it be the hub itself or being at the front with other people there. So just that close proximity, that physical location to others.
And the skills shared through demonstrating, through recognition that different team members had different skills and different contributions, and then decision making made as a team, within team conversations, and sometimes good examples of that, and sometimes not so clear examples of that. But the big point here is we quickly appreciated that it's much more complex than this. There were many movable parts, and it depended on different contexts. So there was much more to these relatively simple questions. And with this, it was really unique what we were hearing, because we were not hearing only clinical voices. The majority of research looking at teams in primary care really look at the voices and thoughts and perspectives of the healthcare professionals themselves. But our work purposely included the broader team, the whole team. And so we had a 50-50 mix of clinical and non-clinical staff being asked the same questions. And so how they chose to interpret what knowledge, skills, and decision-making was varied, and we allowed and encouraged that variety. So just appreciate that we heard some unique perspectives, and so it's actually how we've presented the information is different to how we thought, perhaps. Jump in, Elijah, if there's any pieces to add. So here, important to recognize the unique primary care context, which is complex and is only becoming more acute and more complex in its presentation and its busyness. So some of the early comments were just around the how and why we do it, the reasons why healthcare professionals enjoy working in primary care, being able to empower patients, where we're not just a service that is sort of putting a band-aid on things. We have the opportunity to provide education, resource, again, like empowerment to actually improve their health overall, which obviously keeps people out of secondary care and improves their longevity and life overall. And you'll see other comments here around time being a good thing on one hand. I think time, because we see those patients again. It's not something like you send them home with a discharge summary. You can see them again in 6 months. You can follow them up with a phone call or a letter, versus the time. And we do a similar thing, but often they're all quite busy. So just recognizing that different staff have got different time pressures and commitments. And with the busyness, perhaps forgetting how different people could contribute at different times with skills that they may know. All right. So speaking of teams in general, there were examples of well-functioning teams. And here we've used the cog analogy, and staff working as part of a team, and how one cog might work that impacts the other cogs too. And obviously the patients in there as part of that experience too. So examples here and so they would just upskill us literally on the spot, take us in and show us the pros and cons of this assessment, how to do it efficiently, and where to find the resources for it. And it's the same like with in-house, with our nursing team, constantly spending time dedicated to actually upskilling in those areas. We also do the same with the physio as well, in regards to some exercises to patients. And that's just going and spending time with each other, which this business allows us to do. And another comment here. So I think something that does work well for the patient, as long as the accuracy of the triage is correct when they're booking in, they're usually booked in with the right person for the job. And that's not necessarily just the GP. I don't know, Elijah, if you want to add any comments or thoughts.
I'd just sort of like to add the comment that there were lots of comments that gave us, good examples of well-functioning teams. And obviously, this is just a selection of the few because we can't include them all. But just note that there were lots of really good examples and from, lots of varied roles as well, which just obviously shows the significance of a well-functioning team and sort of how people interpret that.
Yeah, thanks, Elijah. And this comment here, the workforce is under pressure. And I think the best way to deal with the workforce under pressure is not finally having this GP retire and close their books and tell all their staff and move on and tell them to find another place to work. It's nice if that service can continue. The person slowly withdraws, but the team keeps getting revitalized. So I think continuity of care for patients is also teams. So yeah, some thanks, Elijah. So some great examples of well-functioning teams. So the other piece of this was sometimes there were missed opportunities. There was thinking there was other ways that the team, they were nearly operating as a full fluid team, but occasionally there was little stuck pieces. And so that's where we've tried to sort of demonstrate the cogs maybe just getting stuck on occasion here. And there's different examples. Someone's saying, I think it could be done a lot better here, because I think a massive part of it is the person ringing up is in distress. And half of the feeling better thing, a lot of the time, is knowing help is on the way. But when you've got a person going, I haven't got any appointments to book you in with, or I can't fit you in for 8 weeks, for example, then that automatically makes that person feel like they're not as valued. So I think some work could be done in that part of getting the person in as well. Or the working as a team, it's a wasted appointment, obviously, for GP, but also for the patient. Because a lot of these things, I feel like giving a diagnosis for some pills and they're sort of sent on their way. And they're seen for 15 minutes and then that's it. So sometimes I'm feeling that maybe more could be offered. And the one here around the working with the interpreter, and the interpreter is there for the clinical consult, but doesn't necessarily help with the subsequent rebooking, payment, and that linking in with the administration team 2. And sort of here, like a 5-minute appointment tagged on to the end to use that person, the interpreter, and then go to another room and have those conversations that's part of the functioning of the primary care model. So it's not only that at the clinical interface. Any other thoughts there from you, Elijah?
I think for me, that was the important one to recognise, was the interpreter one.
Okay. Yeah. All right. And again, I think, as Elijah said, that we've got other examples, but those are just some of the ones that we've pulled out. And so, and this one was, the big thing was that, there's many teams within a team. Who you ask, depending on who you ask, depending on how that person interpreted where that team started and stopped. So as I said at the start, if you ask a lot of healthcare professionals, they think of their clinical teams that they might be working in. Whereas, you're employed by Health Hub, you're all part of a whole team. So different people interpreted what that team was. And there are many smaller teams working within that larger team. And so how those bits worked and interacted together was noticed as sometimes there were good examples of that, and sometimes perhaps those cogs, those moving cogs, needed a little bit of oiling to keep the bigger teams working as best as they could, as well as within the smaller teams too, if that kind of makes sense. So I think the disadvantages are if it's not communicated properly. So if you've only got a few people knowing what's going on. And I think we're all pretty good at recognizing if we need to link that person into other resources, either within the team or externally, to achieve the best results for that. So a recognition of the importance of knowing all the different things that are going on. And it's kind of like we're not clinical, but of course we're becoming clinical. And then someone speaking about some proper big meetings as a clinic, and that was shared, and any problems or whatever from one to the other, they could discuss it a wee bit. And I think those things are what we miss. Anything from you, Elijah?
Nothing with that one.
And so those are sort of how we saw it. The good examples, teams functioning smoothly together. There's some missed opportunities, and then the acknowledgement of there were very many teams operating within teams. So this is a slide. If we were in person, we would ask for your feedback here as to how well you feel we've captured what you've said. The people we've spoken to, they were pleased with how we've managed to give a bit of order and structure to what they felt were all sorts of different answers all over the place. And we'd really value hearing your thoughts and perspectives as to what you've seen and read and heard. And then the where to from here, or where does this fit within the primary care landscape? There'll always be many teams within the team, but not losing sight of the fact that you're all part of the same team. And so there are multiple important roles in primary care that include both clinical and non-clinical roles, and they're all important to keep the functioning of best care practice for our patients. And as primary care continues to evolve, those different roles and how they operate and how they work with will be important, because caring in this space is complicated. The Litchfield comment here speaks to the title of the article is "You're only a receptionist. What do you want to know for?" And I think that speaks to some of the examples we came here, whereas everyone's part of this team and everyone has got different important contributions for a person's journey. And then the comments here just speak to the change is occurring, and there's the change of the public perception as to what primary care linking into general practice might look like, but also the change in the staff attitudes and perceptions as to what primary care could and should look like. Any other thoughts there from you, Elijah?
Just a personal thought from me, and sort of just to continue on to echo what you've pretty much said, but it's just that with healthcare changing and healthcare changes through lots of many facets. Primary health care is also very multifaceted because there's lots of different parts that intersect with each other. And as we've talked about with teams and within teams, we haven't even included the person, the individual, the whānau, the community. We haven't included those elements within the teams, but that creates a different dynamic again. And so we can see it goes back to that first slide of what we envision primary healthcare to be, and where are these intersections where do we intersect as clinicians, as support people, as whatever your role actually is, where do you intersect with that patient's journey? And so I think that the roles we have are a lot more important than we may give them credit for. And I think that it was really it was notable, obviously, through a lot of the comments that came through, just with the viewpoints that people had. And it was really nice to actually sort of get that spread of different viewpoints. And a lot of it still spoke to the same sorts of things. And so, like Chris said, I think as things change, we also need to be more aware about where we are as a team, as healthcare professionals moving forward as well.
Thanks, Elijah. Beautiful summary to bring things together. So, hey, that's us. Thank you for working with us and being involved in this research. There are just some references there that I share, so they're there. But no, it's important just to say, thanks for being involved. The last piece is what we'd like to do, and one of the next steps will be to present this back to the leadership group at Health Hub. So we've sought the permission from the people that we've presented to face to face. But we'd appreciate your permission to sort of see that this is what we'd like to take back to the leadership team too. So they've supported us with this, but we really would like your permission. So please let us know if you're not happy with how we have interpreted this information and these interviews that we've had with you. Otherwise, that's it. Kia ora. Thank you. And we will share these links with you. Thank you, Elijah.
Thank you.